Hello and welcome to Evolving Paradigms in Castration-Resistant Prostate Cancer. I'm Dr. Charles Ryan of the UCSF Helen Diller Family Comprehensive Cancer Center. And I'm delighted to be joined today by my colleagues and friends, Dr. Oliver Sarter from Tulane Cancer Center, as well as Dr. Dan Petrolak from the Smilo Cancer Center at Yale University. Welcome, both of you.
Thanks, Chuck.
Thanks, Chuck.
Today we're going to be discussing three cases, and as you'll see, they represent really the gamut of what we treat every day as medical oncologists who focus on prostate cancer. So I'm going to introduce the first case to you, and we'll start the discussion. A 67-year-old man presents with low-volume metastatic prostate cancer about a year after having a radical prostatectomy. His PSA is 22. He has no symptoms. He has no visceral metastasis, and he's currently started on an LHRH agonist therapy, which started about 3 weeks ago. Before we talk about what therapies might be appropriate for this patient, why is it important that we know about visceral metastasis in this patient population?
Well, there are a couple things I need to know. First of all, visceral mets, because that would clearly put him into a high volume category if we use the charted definition. But you've used a particular word, low volume, there, that I want to know a little bit more about. Is that the charted low volume definition? If so, I'll tell you what it is, but I just want to make sure there are different definitions of low volume, and so that's part of the case I need to know a little bit more about. Right,
so we're getting to a clearly emerging issue in this disease, which is volume of disease. It's intuitive, but now we're learning that volume of disease really does matter. So I would say when I use the term low volume now, I'm using the charted definition because that's what we think is going to change therapy. So in this case, let's imagine this is a patient with 3 bone metastasis.
Terrific. And you know what's so interesting is that perhaps if you had asked me last week, I might have a pretty pat answer to this, but that was last week and now is now. So this very morning at ASCO, it turned out that there was a presentation on the STAMPEDE data, which influences me. So let me explain a little bit about some of the trials in metastatic hormone-sensitive prostate cancer, and then how that framework is going to determine how I'm going to handle this case. So, and I'll be quick. So first of all, we have a French trial, the JETRIC 15, which really didn't show a lot of activity of docetaxel added to ADT in hormone-sensitive metastatic disease. Then Chris Sweeney, last year at a plenary session, gave a remarkable presentation where the patients with high volume metastatic disease, and his definition of high volume was either visceral mets or at least 4 bone mets, one of which had to be outside the vertebral column and pelvis. So if you had that definition, it turned out there was a 17-month prolongation in overall survival with adding docetaxel to ADT. Really, really impressive. Hazard ratio about 0.6. But then there was this low volume subset, and that's where this guy would be. He'd be a low volume case, where it really didn't appear as though there was a statistically different finding with regards to overall survival, but the hazard ratio was about the same. And what was really going on is they really didn't have enough events to really drive a confident scenario, at least from my way of looking at conclusions. Now, we now have the STAMPEDE trial, which is UK, big trial, over 1,000 patients. They did not use this definition of high and low volume subset. They just said metastatic, non-metastatic. Well, in the metastatic group, they had enough mature data to be able to say 22-month prolongation, median survival with the addition of docetaxel. Very, very impressive. I asked Dr. James personally before the conference, did you separate anything out low, high volume? He said, no, we don't have that data. So I don't know. When we look at this case, it's low volume by charted, but it's metastatic by the STAMPEDE. And so the question is, do we pull the trigger or not? And I'm more liable today than I was last week to add docetaxel. And I'm going to cite the good hazard ratio in the charted trial and the new STAMPEDE data, and I'm going to let the patient know what I think, and then I'll let him make the final decision.
Right, so Dr. Petrolak, I'd like to know your thoughts on that answer, but also tell me, what's different about giving chemotherapy to this type of a patient versus one who has castration-resistant disease?
Well, firstly, it's a fixed number of cycles. It's 6 cycles that we administer. We don't administer prednisone with that, as opposed to with castration-resistant disease where we do give prednisone. My feeling is that, at least the impression I've had, is that it's better tolerated when you give it earlier, when they have hormone-sensitive disease, rather than when you give it later, and they may be a little bit more advanced, may have more bone marrow suppression because their bone marrow is more infiltrated with tumor cells. So it's 6 cycles, no steroids, as opposed to steroids with castration-resistant disease. There's one thing I think about this case which stands out. This is a patient who relapsed 1 year after prostatectomy. And he's just seeing hormone therapy now. He must have an extremely rapid doubling time if his absolute PSA value is 22, or perhaps he never nadered after the surgery occurred. In my experience, this patient is in big trouble. Generally, if you don't nadir your PSA, or if you have this rapid PSA rise after surgery, you're going to develop metastases per the Parton table within about 4 to 5 years. So I would be very inclined to give this patient upfront chemotherapy for those reasons.
Yeah, I totally agree. A PSA of 22 a year after a prostatectomy is a significant warning sign, independent of what it was 3 months ago or 6 months ago, the rate of rise. Let's entertain the situation where, say, everything is the same here with the patient. However, he doesn't have metastasis. Dr. Sartor, would you consider chemotherapy with hormone therapy in a non-metastatic patient who
I would
has a
not.
rapidly rising PSA?
Yeah,
You would not?
I would not. I think that we do have some new data, and again, I'm going to be quoting the Stampede trial because they looked at that non-metastatic subset. What they had was very few events with regard to overall survival, but hazard ratio is basically 1. They had a very good PFS, progression-free survival, but I'm not really willing to change my paradigm of care based on a PFS in this setting. So if he's non-metastatic, I'm not going to be using the docetaxel.
Okay. And Dr. Petrolak, what about you? What about in the case of the setting, going back to the setting with bone metastasis?
Right.
We saw some data today. Zoledronic acid, are you adding it at this point?
Up front, no. I'm not going to be adding it. But I may actually differ with you a little bit on that answer. The reason being is that we do see a PFS benefit. The data is not mature enough yet for us to see an overall survival benefit. So this is, again, a patient who has rapidly progressive disease. I think he'd be perfect for a clinical trial, but I think you should at least have the discussion with the patient that the data is not yet mature, and that perhaps we would see a difference if we added chemotherapy. So I think that there may be some benefit by improving PFS, but I think that the patient should also be involved in that decision. It should be a shared decision-making procedure.
I would also add that we saw the Stampede data that looked at this cohort a little bit. Michael Morris presented, it was in a poster
Absolutely.
yesterday where they looked at rising PSA patients. I believe it was at the doubling time of less than 9 months, who were randomized to ADT versus ADT plus docetaxel. And there was a modest PFS benefit seen there. That's a study that took a long time to develop. A lot of issues around who is sponsoring that study, and so it's unfortunate that we're getting this data so late, but it also supports, I think, what you just said, which is maybe a modest effect on PFS. And every time I see something like that, I think, well, there may be certain individuals for whom this is the appropriate approach, and we need to tease that out.
Especially in an aggressive case like this.
Especially in an aggressive case like this. And so one of the issues about looking at medians of clinical trials where 700 patients were treated or 300 patients per arm were treated is you have to know that there's a spectrum of response. And that's our job as researchers to try to sort out who those individuals are who should or should not receive those more aggressive treatments.
Agreed.
So it's a good discussion. I want to just take it a little bit further. We had new data at ASCO this year, going even a little bit earlier for patients with localized disease, high-risk localized disease. An NCI-sponsored radiation therapy oncology group study, you've been involved with them, looked at docetaxel plus ADT. And Dr. Petrolak, what are your thoughts on the integration of chemotherapy to radiation?
Well, I think that this study is showing a PFS difference, but it's not showing an OS difference. That there are a small number of prostate cancer deaths from this trial. It's not really yet mature. So this technique is not ready for prime time at this point.
I think the same idea applies. There probably are patients in whom chemotherapy is the appropriate approach, but it's not something that we should apply broadly. I look forward to subset analyses from that RTOG study that might help explain maybe there's a benefit in certain Gleason scores or things like that. Dr. Sartor.
Well, it's very interesting. There was a one-sided p-value, which is not conventional, and Ian Tannick picked on that a little bit during the discussion. And when you look at a one-sided p, it did turn out to be less than 0.05.
Right.
However, on a two-sided p, it would have been 0.08, and that was overall survival. But as Dan pointed out, there really were not that many prostate cancer deaths, and what was odd, perhaps perplexing, is that a number of patients in the docetaxel treatment arm had lower numbers of second cancers,
Yep.
lower numbers of other deaths were not related to cancer. And what does that mean?
Right.
So I agree completely with Dan. Not ready for prime time. This stuff needs to mature a lot more.
Right.
And who knows? Maybe 3 or 4 years we're going to come out with subsets that make a real difference, but not now.
Well, it is interesting. In that study, they had the study plan called for 400 and some events, 435 or something like that, and they had those events did occur. And to a large extent, that study was looking at a difference in early death from prostate cancer. And it did see a slight difference. And so by maturing data, I think what you're referring to is the fact that most patients who get treated with curative intent, experience a relapse, get treated and go on to die of prostate cancer, that is a much longer than a 4-year natural history. And so we're just taking a snapshot after 4.5, 5 years.
Exactly.
So it can be interesting to see where that goes. So either one of you want to comment on the issue? I brought up the issue of zoledronic acid, which I think is an important one to tease out. We've now had a number of studies which have shown that it really doesn't add too much in cases like this. Just to close up on this comment, on this case of what's the appropriate therapy for this type of patient, we're doing ADT. We're doing bicalutamide, which has been included in the chemotherapy studies.
Right.
For what that's worth, and that's a conversation, that's a discussion item. And then the docetaxel, but with no prednisone. I think those are the key points. But it is quite common to see patients who are receiving bone-targeted therapies in this setting of early metastatic disease. Anybody want to comment on what we might see coming down the road in terms of what's being integrated into this group of patients?
Yeah, so what's really interesting is, if it works in late stage, now everybody's moving it up. The abiraterone plus conventional ADT has already completed accrual by the Stampede group, so that's going to be reporting. There was a celecoxib study, and that closed early for no efficacy, so celecoxib is not the answer. And then there's also accruing now a combination trial with abianeza together with ADT, and then there's an ODM-201 study, and there's a proposed radium study.
Right.
So before you know it, we got ODM. I'm sure there's Darian 509 as well, although I don't quite know.
About that.
There's actually a 509 trial in low volume disease, if I remember correctly. So there's one out there covering the other group of patients.
But nevertheless, when you look at the new agents, it turns out, tick mark by tick mark, they're trying to move forward into this space, but all of a sudden it's become very complicated because the standard of care is changing.
Yes, well, I think we all have to hand it to our colleagues in the UK who are able to pull off this study. What is it, 7,000 patients who are enrolled?
Yeah.
It has to be virtually every patient in the UK who's diagnosed with newly diagnosed metastatic prostate cancer who's somehow involved in this trial, because there are many arms, and I think we're going to see that this will alter the standard of care more as time goes on.
Right.
So it's a very interesting time. One of the issues that I keep coming back to is, in reality, this is a relatively small group of patients in the grand prostate cancer scheme who go right from localized disease to metastatic disease. And maybe this is an opportunity for us to discuss when is the optimal time to start ADT. In this case, it's pretty obvious. He's got a relatively high PSA, bone metastasis, but the most common source of referral into my clinic is a patient who's had radical prostatectomy or radiation, and his PSA is climbing and his scans are negative. And we did have some presentations on that topic today about the morbidities of ADT and whatnot. But what is your approach, Dr. Petrolak?
So I look at the time from their local therapy to the PSA rise. I look at the PSA doubling time. I look at their Gleason score, and I also look at the patient to see whether they can really tolerate ADT or not. If there's somebody who's obese or has cardiovascular issues to begin with, these are patients that I'm a little bit more reluctant to start ADT on quickly. In a non-metastatic patient, I generally will treat these patients intermittently, 6 to 7 months, followed by restarting their hormone therapy at the appropriate either absolute PSA value or doubling time. So 6 months is usually my cutoff, but again, I try to take the overall clinical situation into consideration.
Dr. Sartor?
Well, I'm glad you asked him first, because it's a really hard topic. And I've given many lectures and written on this topic as well, and I admit that it's very confusing. So first of all, we have to weigh the potential benefits, which quite frankly are a bit unknown, against the potential harms which are known. And as Dan pointed out very clearly, there's some individuals that are going to have more harms. Those that are obese, those might be diabetic. You really do end up with some glucose intolerance issues. It is not always a well-tolerated therapy. In some men, they may have a substantial amounts of fatigue, maybe even depression. So there are real issues with regard to the harm side. The upside is a little bit harder to define. And at times the PSA anxiety is really just driving men crazy. I must admit that the slower the PSA is rising, look at the PSA doubling time, just as Dan did, that I'm really more conservative. And if it's faster, I'm a little more aggressive. And I do exactly what Dan does. When I do use it, I use intermittent. I typically use 6 months on and then try to let them recover. I always measure testosterone, by the way, because if I don't know what the testosterone is, I don't really know how to interpret the PSA. Some men have a prolonged suppression of testosterone even after only 6 months of ADT. And other men, boom, they're popping right up. So if I'm going to be using intermittent, I make sure I monitor the testosterone too. Now I get to ask what you would do.
Well, I would do, I have historically had the following rule. A PSA doubling time of greater than a year, I typically don't recommend therapy. A PSA doubling time of 3 months or less, I typically recommend ADT. And in between, I typically recommend something in between. And usually in our case that we're doing some kind of a clinical trial, we now are looking at intermittent ADT in combination with novel AR targeted therapies. So those patients are all getting something hormonal. But I was very intrigued today. There was a presentation on intermittent versus continuous ADT, and I don't know if you caught this, but there was a significant increase in the risk of venous thromboembolism in the patients who were receiving intermittent hormonal therapy versus continuous. And that brings something to my mind that I hadn't really thought of before, which is the flux of testosterone, the up and the down of the testosterone, is there a potential harm in that? And the discussant said that could be an estrogen-mediated phenomenon, and I'm going to really have to think about that. It was quite a significant increase. I don't know what your thoughts are.
Well, but there were a couple of issues. I mean, number one is they did measure estrogen. Number two, they didn't even measure testosterone. And when you're looking at adverse events, and I've got a lot of experience in the data monitoring committee world, and we're looking at adverse events after adverse events, we're looking at thousands and thousands of them. Yet, we never do a Bonferroni correction for the multiple looks. And Tia pointed that out in the discussion that, hey, you're looking at 50,000 things and this one pops out. Well, is it really chance or not? So I'm not quite convinced. I'm not quite sure what to make about it myself.
And the other way to look at this is that there is some evidence that LHRH agonist therapy may actually promote inflammation. And that may be the source. And there's this data that has been analyzed retrospectively with the LHRH antagonists, that there may be a lower rate of cardiovascular events. These studies with the intermittent therapy use the agonists. So, there's a lot that needs to be investigated from a immunological inflammatory basis that may actually promote this.
It's a very, very, very interesting point.
I'd be pretty reluctant to say that that's a real effect based on this retrospective analysis. I think we're just going to need to have more data.
It needs to be looked at prospectively.
Okay, good. Let me make another transition. We've started with this patient with metastatic disease and the issue of chemotherapy and LHRH therapy, and we kind of went earlier and talked about when to start ADT. Let's talk about what we do with patients after we give them chemotherapy in this setting. The reality is most of them are going to experience a progression to CRPC at some point. What are your thoughts on how does the prior chemotherapy affect your perception of how to treat them with CRPC?
So right now, without any other evidence, I'm going to run the playbook exactly the same way I would do otherwise. And the reason being is that going back to the original phase 1 study with Taxotere, the third patient we treated was a gentleman who had a really dramatic response for about a year and a half, then went on to receive 2 other phase 1 trials, progressed on those trials. And his wife came barging into my office and said, please, put Mr. So-and-so back on docetaxel. He's done so well on it before. And I sort of looked at her like she had 3 heads, because why should something he was resistant to and progressed on, why should he respond again? And lo and behold, this patient responded again beautifully. And there is this phenomenon that you can retreat patients with taxanes. particularly if they've responded the initial time. So whatever the resistance mechanism is, it may actually be transient, it may require continued drug exposure. So I think we really have to investigate this carefully, because we really don't know what the effect of the first 6 cycles of docetaxel is, and it's certainly possible that it's going to have no effect, particularly if it's a long duration from the initial chemotherapy administration.
And by no effect, you mean that the disease will still be sensitive
It'll
to
still be
taxanes.
sensitive, exactly. It'll still be sensitive.
Because the patients were not treated to the point of resistance.
Correct.
They were treated for 6 cycles, presumably during the time of sensitivity.
Right.
Your thoughts?
Well, I think he's bringing up something a little bit different too, and that's the plasticity in these cells.
Right.
One of the things that I've really come to appreciate is that there is some degree of heterogeneity in these cells. We impose a selective pressure. We call that treatment. And then the plasticity of these cells is such that some of the sensitive populations go away, the resistant cells rise. And so after a while, we change therapies. But then when we remove the selective pressures, things can come back to like they were. And this is not only true with docetaxel,
Exactly.
I've also seen it true with abiraterone. So I put a patient on abiraterone, they're clearly resistant. I come back, I treat them with 2 or 3 different other things, and I come back to the abiraterone, and lo and behold, I get another response, even though it's a resistant patient. So, I'm really trying to figure out how I can get smarter and figure out what those cancer cells are doing so I can bring in the resistance drug to fight the resistance of the first drug, and it's just like, oh my goodness gracious, it's complicated, but it really is interesting. And by the way, I hope we can have a little chance to talk about some of this stand up to cancer stuff, East Coast, West Coast stuff.
We're going to talk to it.
Yeah, that's really cool.
But there are trials that are now being designed to look at that particular question. So for example, there have been anecdotal reports, as you've been saying, of patients responding to either enzalutamide or abiraterone after going on chemotherapy. And perhaps what you're doing is you're wiping out some of the ARV7 clones that may have given you the resistance pattern to those drugs in the first place. So, I think for a while we all thought that it really didn't make a difference what your prior chemotherapy was, that the docetaxel line for drug approval was sort of artificial. I think it may be a little bit more real than we originally realized. And I think that there actually is a clear effect in some situations on the subsequent drugs that you administer.
Very interesting times. And just to close up on this point, for patients in whom you have metastatic disease like this, we give docetaxel. I mentioned earlier that it's highly likely that all of them are going to subsequently develop CRPC. Do you ever do intermittent hormonal therapy in these patients? If a patient has a good response, would you consider discontinuing the ADT? I know there's a lot of questions about this in the community.
No. If they are metastatic, and this patient was metastatic, I will treat them with androgen deprivation for a long, long, long time. And then I'm going to tell you about the trial very briefly where we administer testosterone. And I'll just say it's a very intriguing concept, but it really needs to be done in the clinical trial.
Absolutely.
I think that you have to look at the individual patient. I recently had a gentleman who had metastatic disease, had an excellent response to hormone therapy. He had resolution of one of his bone metastases, and nothing was there, but he could not stand androgen blockade. He really did very, very poorly. His energy levels were low, had constant hot flashes, and so he was very symptomatic from his blockade. We had a long discussion about what the data told us in the situation, and he decided to come off therapy. So I think you've got to individualize it. I mean, we know from Maha's Hussein study that there is a 6-month difference in favor of those patients who are on continuous blockade. Yeah. But again, at what cost and quality of life to the individual patient are they willing to sacrifice? And I think that's something you've got to consider.
I'm just going to say I agree with Dan in an individualized basis.
Yeah, those are both really important points, and I would say that my standard for metastatic disease is to do continuous androgen deprivation therapy. I have individualized it in the case of the outlier responders or the outlier toxicity cases. And we'll get to this in the next cases, but one of the interesting aspects of the use of chemotherapy plus ADT is we're not treating to the point of resistance. These aren't patients with CRPC, so they don't have a disease that is hypersensitive to testosterone. So continuing the ADT is perhaps more important in the CRPC setting than it might be here, because that's a more evolved tumor. And that's something that I think is worth noting, and just from a practical clinical standpoint, to know that we're talking about a different disease state here. So there's been a great conversation about treating patients with metastatic hormone-sensitive disease, as I like to call it, and the evolving standards of care that we're seeing in this group and the new data that we're seeing even just a couple of hours ago.